and that will be, we're looking at HIV testing services in children. And to do this presentation, we'll have Dr. Meg to do it. She will give her full profile introduction as she comes on board. I want to welcome our network across the country from different corners. I can see the Zambezi District Hospital, Western Province, Mongu, Yellow colleagues from different places. Thank you very much for joining.
Good afternoon, network. I think we just lost Dr. Ziambo, but Dr. Meg, please, over to you. You can go ahead and start the presentation.
Great. Well, good afternoon, everyone. Let me share my screen real quick, and I hope you guys can hear me okay. So once again, my name is Meg Itoh. I am the Care and Treatment Advisor for CDC Zambia. Been working closely with the ministry team as well as partners on all issues pertinent to pediatrics. And so today's talk is on updates on pediatric case finding, which, as you all know, is a very, very challenging aspect of the pediatric program as we near epidemic control and there are fewer children to be found. And that being said, even though we've reached epi control for the general population, we're still only about 70% of the CLHIV having been found and put on treatment. So we need to find the remaining children and bring them up to speed with adults. Okay, so the learning objectives of today's talk is to, number one, discuss the strategies for scaling up case finding among children, and then talk about the different modalities for testing in children with specific focus on PITC or testing in OPD, as well as family index testing or the Know Your Child Status campaign. And then also to ensure that we're retesting negative pregnant breastfeeding women so that we can identify incident infections among this population to prevent mother to child transmission. And then I also want to take this opportunity to introduce the idea of KYCS Plus, which I'll obviously go into, and then the register that goes with it. So on to the talk. So this is a snapshot of where we stand with our pediatric gap. And so using data from Q1, which is December 2021, we show that we're about 70% of CLHIV coverage, with the biggest gaps in Central, Copperbelt, Eastern, and Lusaka provinces. Some of the smaller provinces like Muchinga and Western, they've actually closed their gap quite a bit. And so they have fewer than 1,000 children to be found, which is great. You know, and that's assuming these estimates are correct. But we also recognize that these last, few hundred of children that we need to find will be the hardest to find. So you might be familiar with this slide from my other presentations, but basically the point that I wanted to make in this slide is that at this point in our epidemic, we've done a fairly good job identifying the low-hanging fruit that's indicated in orange. So these are the sick children who show up in health facilities, whether it's inpatient, outpatient, and TB. But of course, we don't want our children to be diagnosed at this stage when they're already having symptoms of HIV. And so we want to find them when they're still healthy and put them on treatment so they can continue to live healthy, normal lives. We've also done a pretty good job testing children who are brought in by their caregivers for testing, whether it's through VCT as part of index testing or through early infant diagnosis for the HIV-exposed infants. But the hard to find children remain, and this is where what we're talking about. So we know that there are children and adolescents who are well and are not accessing health services. And so we're trying to get to these children through family index testing, or KYCS. And I think these are children who remain well because the dynamics of HIV infection among children has changed from years ago when there was more, prenatal infection happening. So if a child is infected during breastfeeding, for example, they may not develop, symptoms very fast, and they may not die. And by their, the often quoted statistic of 50% of HIV positive children dead by 2 years of age. That may not necessarily apply for children who are diagnosed later in life. So family index testing is key to find these children who remain well and not accessing health services. We also know that there are orphans and vulnerable children in the community who may not be captured through KYCS. And this is where the community testing partners play a key role. And I'll talk about that. It's also important to ensure that that we're testing negative pregnant breastfeeding women to identify those babies who are born to mothers who have an incident infection after ANC1. So with that, and then also want to make sure that we are, the HIV exposed infants are getting their 2-year final outcome. We know that we've done a good job testing exposed infants at birth as well as at 2 months. But when it comes to later testing, so testing at 12 months and then also at final outcome, that coverage really becomes low. It's about 50% at the moment. So with that, I think we'll go into our first poll question, which is, which testing modality contributes the largest proportion of pediatric testing volume right now? The first answer is index testing through Know Your Child. Number 2 is PITC, which is mainly OPD. Or number 3, both 1 and 2.
Thank you so much, Dr. Meg. And
Great.
I hope we are able to see the poll questions.
Yeah. Let me know when I should stop. It seems like things, well, maybe everyone's answered. Okay, so I will end the poll. Should I just hit the end the poll button? Okay, done. Okay, so I'm sharing the results. Okay, so 47% said index testing, 12% said other PITC, and 41% said both 1 and 2. So this was kind of a trick question because technically all of you guys were correct. So depending on when you were talking about, so this is showing the breakdown of the different testing modalities, by testing volume by different modalities So as of FY21 Q4, which was as of December, sorry, not Q4, as September 2021, index testing was 51% versus 28% of other PITC. But as you all know, we suspended the use of the risk screening tool in OPD for children. So as a result, the number of tests done in OPD has skyrocketed. And so as of Q2 this year, the number of tests done in PITC comprise of 54% of total tests for children, as opposed to 31% for index testing. So that's the situation that we're in right now. And I'll talk a little bit about the impact of the screening tool suspension. But let's move on to the next question. Okay. So the next question is, which testing modality contributes the largest proportion of positive children? The first is index testing. The second is other PITC. Third is both 1 and 2. So please go ahead with your answers. It looks like we have about 60% of you answered already. So I'll give you guys a few more seconds. Okay, it looks like it's stabilized. So I'm going to stop the polling there. So great. So 58% of you said A, index testing. 17% said other PITC, and 25% said both 1 and 2. So this one is a little bit more straightforward. So the answer is 1, index testing. So despite the fact that other PITC testing volume increased significantly in Q2, you can still see that index testing comprises the majority of where we're finding the positive children. So that's really important to keep in mind as we discuss, how we're going to be scaling this up. Okay, so what about the other modalities, right? So I'm showing the other PITC and index testing volume on the top, and then the positives at the bottom on your left. And I had to put these on separate axes because the number of tests in the positives really dwarf the other modalities. And so here you can see that we essentially doubled the testing volume in other PITC, but unfortunately, we actually decreased the number of children identified through OPD from Q1 to Q2. We did see an increase in KYCS in index testing, and we saw some increase in the number of positives. And then in terms of the other modalities, so this is ordered in from high to low based on Q2 testing volume. So paediatric modality, which is essentially under 5 clinic, did the most number of testing next to index testing and PITC. But relative to the volume of testing done, they actually did not find that many children. This in comparison to, for example, TB, where we're still doing a fair number of tests, but at the same time, we're actually finding a lot of positives in this modality. So it's really important to make sure that we're doing tests for all eligible children in TB, since this is a high yield modality. BCT, it's a little bit of a strange modality for children because we think that this is most likely representing index testing as well, because this is where the children are brought in by their caregivers to be tested. But it really should be classified as index testing. So just wanted to pause and reflect on the impact of the screening tool suspension in this slide. So as you recall, the reason why the risk screening tool was suspended in the first place was because, as you can see on the left, the volume of tests done compared to about 2-3 years ago in FY19 compared to FY21 decreased dramatically from about 300,000 tests to 45,000 tests. And part of this was intentional, right? We wanted to test fewer, but more efficiently and smarter, and didn't want to, miss out on testing children who should be tested. But unfortunately, what happened was, we had a 84% decrease in the testing volume, but we also had a 72% decrease in the number of children identified in between these two time periods. So we said, wait a minute, we may be screening out too many children who should be tested. And so as a result of that, the ministry put out a notice to say we need to stop the risk screening tool just for children. And this was implemented around Q1 of this year. And so what have we seen since then is that we went from 45,000 tests to 96,000 tests among children, so essentially doubled. And then the number of positives did increase, but only about 17%. So not a significant increase. But that's still important because we need to find every single child, right? Every child matters. But of course, we would have liked to see more of an increase in case finding for children with the suspension. But we also recognize that suspending the screening tool in its entirety didn't exactly happen because many facilities had limitations in test kits, and so they still had to do some level of screening for children. So what now, right? Do we keep suspending the screening tool? And I think that's a big question in the back of our minds. And for now, the answer is still yes. But I wanted to share that we have the results from the validation study that are currently being analyzed right now. And they're hopefully, fingers crossed, they're going to be ready to be shared in July. And so based on the findings from this study, we will likely develop a new risk screening tool. One that is hopefully easier to administer consistently across facilities, and that would allow us to be more efficient at testing while avoiding screening out too many children who need testing. And I should note that similar validation studies from similar countries, similar contexts, have shown that positive maternal HIV status, as well as questions asking about poor growth of a child, have a high positive predictive value. So, questions like, is your child growing as well as, children of his or her age? Those types of questions to get at whether a child is growing well or not have been very helpful in screening in those children who need to be tested. So anyway, I think these two questions will play a prominent role in our risk screening tool that we will develop in the future. Okay, so moving on to family index testing, or the Know Your Child status. So how did we do with KYCS this year, right? We know that there was a big push to conduct KYCS as part of the pediatric surge. And we know that, the pediatric surge facilities were mainly the high volume facilities in your provinces. I know there were certain provinces that were very ambitious and decided to do the surge pretty much everywhere, but as a whole, I think most of the surge facilities are large volume facilities. So you can see here in their data that last year we had this increase in index testing, as you can see in the blue bars. But what you see here in the orange bars is that the number of positives didn't really budge very much, right? And it went up a little bit in Q2, but honestly was essentially stable. It has been stable for the last 6 or so quarters. So that basically calls into question, are we doing KYCS in the right places? Have we squeezed out all the children that we need to find? And we know that when we look at our data, we are finding relatively more positive children out of the smaller to medium-sized facilities. And so we know that since KYCS is really more of a surge activity, or has been a surge activity, we need to make sure that some of these smaller facilities are also doing KYCS, that these numbers are coming from those smaller facilities in order to find additional children. And so moving forward, the goal is to ensure that KYCS is being done everywhere, including those smaller facilities, and that every child is being tested. And we know that when community health workers go out to homes, sometimes children are away at school and they can't be tested. And so we need to make sure that those children who weren't captured initially should also be captured. And then in addition to ensuring that KYCS is being done at all facility levels, we're also rebranding and expanding KYCS as KYCS Plus. And so the question is, what does this mean, right? And so we know that pediatric case finding is our biggest challenge, biggest gap. And we want to leverage the platform that we have, which is index testing, to find as many children eligible for testing as possible. And so this means not just the biological children of women living with HIV, but we also want to include any child living in the same household. So if there is a child under 19 living in the household, as the same household as the woman, regardless of the biological status, they should be part of KYCS Plus. And so, that's why we're, including these other children who may be living in the same household. We also want to make sure that siblings of children living with HIV are included in the testing efforts. We know this should already be done. It's part of index testing. A child could also be an index case, right? And so their siblings should also be tested. But we know that that's not always being done. And so we want to make sure that siblings of CLHIV are also being tested, as well as the parents too. This is the register. So we're introducing a new register called the KYCS Plus register as part of KYCS Plus. And we know that some facilities are already using a KYCS register that I believe UTH developed, and this register will replace that version. But hopefully the goal is that this register will be rolled out nationally. And I'll take a few minutes today to go through this step by step so that you're familiar with it. But really the main goal is to standardize the documentation process for all partners so that everyone is reporting KYC's completion rates correctly across all facilities. So step number one of this register is to collect maternal information. So here, basically, each facility would list every woman at a given facility, and we're not putting any sort of upper limit age boundaries on this. So any woman receiving ART should be included in this register. And so you put the names in, ART number, and then this question: do you have any children under 19 living in the household, or any living biological children? So if a woman is not living with her biological children for any reason, they should still, answer yes. And so if the answer is no, I don't have any children, or I don't have any children living with me, then this is a hard stop. You just stop collecting information of that woman there, and that's fine. But if yes, you want to go on to find to document their address and their contact information. And so the total number of women answering yes to this question is going to be the denominator for your KYCS coverage calculation. And so again, I want to reiterate that the main difference between this and KYCS Plus and the old KYCS is that we're not putting a limitation in the age of women. And then we're including all children under 19 living in the same household, regardless of biological status. And so step number 2 is going to be about the children. So you want to list all the children in the household and then tick in this column if they're biological, and get their sex and age information, their current HIV status. And here, the important thing to note is that if a child is negative, that negative status needs to be verified with documentation, meaning like an under 5 card or some sort of a health record that says the date of the test and the result. Otherwise, we need to consider the child's status as unknown. And so any child with an unknown status should receive a test. And that's pretty obvious. But then if a child is over 10 years of age and has had a negative test, has not had a test in the last 6 months, then they need to be retested. This could potentially be changed in the future because it's possible that if we set the age cutoff at 10 years old, then we are going to run into a lot of children who are going to need retesting. But the consensus right now is that as the age of sexual debut becomes lower, and also this depends on the context, right? I think the rural areas have lower age of sexual debut compared to the more urban areas, but 10 years seem like an agreeable age cutoff for now. We may have to change that in the future if we end up testing too many children and we run into test kit problems. But anyway, so any child over 10 years or any child with reason to expect that they've been exposed to HIV risk should be retested if they have not been retested tested in the last 6 months. And also it's important to note that all HIV exposed children without a 24-month final outcome should be retested or should be tested as well. So that's step number 2, and that's all about the children. And then step number 3 is the testing. So we want to indicate the type of tests used. So that depends on the age of the child, right? Most children will likely require a regular RDT. But if it's a child under 12 months of age, then they will need nucleic acid testing, DBS. And so that would be number 2. It's also possible to use self-testing if a child, for example, is not available to be tested at the time of the visit. And then in that case, like you want to either, give a self-test, leave the self-test with a caregiver if they're comfortable doing that, or refer to the nearest facility. Let's say, the tester doesn't have a DBS kit available to test a baby, for example. And then the next several columns will be used to document the number of follow-up. And then the test result. And if it's obviously positive, then you need to make sure they're being linked to care. And so you want to document the ART number. And once every child's status is known, is determined, then you can tick this box. And so, if a child is being referred for testing, then you need to come back and make sure that the test has been done and document the final result. And so the tally at the bottom of the page of this tick mark, so the number of women whose children have been tested, that's going to be the numerator to determine the coverage of KYCS. This last comment section is going to be very important in essentially documenting any relevant details. So for example, if a child is an exposed child without final outcome and needs retesting, you want to document that. If a child is positive and needs confirmatory testing, this would be a good place to document the result as well. Or things like, if the mother has a biological child who needs testing, but, for whatever reason, the child has not been tested, then that information should be documented as well. So anything relevant should be in the comment box. But then I'm sure everyone's asking, oh my goodness, we have a new register, and this is going to be a lot of work. But I want to say that facilities that are already using Smart Care to bind the children to their mothers can continue to do that, and that will be an option, alternative option to using this new register, as long as you're capturing all the information that is reflected in the register. And we're working with IHM right now to be able to reflect what's in the register in Smart Care as well. Because the ultimate goal, once again, is to be able to report the KYCS Plus coverage across all facilities in a consistent manner. So the goal by the end of this COP, which is September 2022, which is in 4 months, is to ensure that all facilities complete steps 1 and 2 of the register. So essentially, getting all the women's information and the women's children's information. And not necessarily, the testing information of the children. So, or you want to complete the binding process of all the women receiving ART at that facility, so that, starting COP22 in October 22, all facilities will have a denominator, a starting point to start reporting their KYCS coverage next year, so that they're going to be asked to report what coverage are you at right now, and with the goal to reach 100% by the end of next year. And so we want to be able to do this consistently across all facilities, across all partners. Okay, so now moving on to PMTCT. So again, I also want to reiterate the fact that, we've done a good job doing 2-month EID testing, but the final outcome status is quite low. So we know this is from last year at the end of APR 21. Basically, there about 35,000 final outcome results were reported, of which about 10,000, almost 11,000 were unknown. And so really only about 25,000 children had some sort of a final outcome reported. And so if you look back 2 years from then, so that would be 2019, and look at the proxy number of exposed infants born that year, it's about 53,000. So knowing that, we barely reached 50% of getting the final outcome results for the exposed infants born 2 years ago. So we really need to make sure that these exposed infants are tested either through KYCS or some sort of a mop-up campaign to track down the exposed infants. So here we're going to go to another poll question. So according to the latest spectrum estimates, what is the most common source of new pediatric infections due to mother-to-child transmission? Number 1, from mothers who were infected during pregnancy and never initiated ART. Number 2, from mothers who dropped off ART during pregnancy. Number 3, from mothers who were infected during breastfeeding and never initiated ART. Or number 4, from mothers who started ART late in pregnancy. Oops, it looks like we got the wrong poll. Here we go, sorry.
Hi, Dr. Meg.
Hi, Dr. Ziambo. Okay. Dr.
I
Ziambo?
hope you can hear me now.
Yes, we can hear you.
You can hear me?
Yes, we can hear you.
All right, thank you so much. Okay, so we do have the poll results. You've managed to share?
Okay. All right, you share results. Can you see that?
Yes, I think most people thought that was the correct answer. So maybe you could carry on with the presentation.
Sure,
Thank you.
yeah. So for these about half of you thought it was option A. 17% thought it was mothers who dropped off ART. 22% thought it was mothers who were infected during breastfeeding. And then about 13% thought it was those who were started ART late in pregnancy. So the correct answer is actually C. So this is a stacked bar graph from the spectrum estimates showing the number of new mother to child transmissions and the source of each infection. So basically the spectrum estimates for Zambia is estimating, about 3,000, what is that, about 700 new infections. And this is based on a model. But these different components of the stack of the stacked bar represents the source of the infection. So you can see that the biggest component here is at the top in orange, and these are mothers who were infected during breastfeeding. So they had an incident infection during breastfeeding and were never initiated on ART and therefore transmitted to their babies. I'm also highlighting the ones who were infected during pregnancy, which is the bottom orange bar here. And that's also a fairly sizable contribution. And then this one, second biggest one is this started ART late in pregnancy and the child was infected during breastfeeding. So in our context, really the risky time period is becoming more the breastfeeding period, right? Previously had been during pregnancy, but now we really have to think about detecting infections during the breastfeeding period and preventing mother to child transmission. So making sure that these newly infected mothers are initiated an ART in a timely fashion. And also that the exposed infants are started on prophylaxis so that you prevent or minimize the chances of mother to child transmission. So how did we do with retesting of the negative moms, right? Because the only way to detect these incident infections is to make sure that these mothers who are negative are receiving testing on a periodic basis. And so here, the testing modality is the post-ANC1 modality. So we know that, testing at ANC1 in Zambia is quite high. I forget the exact figure, the most recent one, but it's high 90s. So we were doing a good job testing those women who show up at ANC1, but the ones who are negative at ANC1, we need to retest them. And so that number, while it has been scaled up in the last few quarters, you can see it was 33,000 in the last quarter, but we know that there are about 120,000 negative women each quarter coming to ANC. And so we still need to do much more retesting. Now, this gets a little bit tricky because we know that there's so many women who need to be retested, and yet we're dealing with limited number of test kits. So for next year, we're really planning around scaling this up. And so we're planning for additional test kits, but at the same time, we need to be very smart about when to retest these women. And I know that the national guidelines say you have to basically retest every 3 months, which is a lot of tests. And so what we're going to be recommending is a more systematic way of testing in the postnatal period. So that align, and these are time periods that should align with the baby's EPI schedule, so at 9 and 18 months. And so if we can retest, all the negative breastfeeding women at 9 and 18 months postpartum, then we should be able to increase these numbers and capture many of the incident infections. Okay, so the last bit I wanted to discuss briefly is the focus on community partners. Next year, even now, but especially next year, we're going to be focusing more on community-based testing, knowing that there are many children who may not be accessing healthcare facilities. And so, as I mentioned, if a child was infected during breastfeeding, then the disease dynamic is such that they may survive into older childhood without overt symptoms of HIV, and may not show up at a health facility to be tested. And so these kids may only be found through family index testing. But if these are children who are orphaned or aren't necessarily captured through an index parent, they may not be tested. And so this is where the community partners or OVC partners are going to play a huge role in making sure that we're targeting testing on these hard to reach, hard to find children. I also mentioned here that social network testing is going to be important for older adolescents or just adolescents in general, who may be more likely to be infected through horizontal transmission. So this is really just a schema to show that OVC and community IPs are foundational in the success of our pediatric, achieving our pediatric priorities, and not just case finding, but also to ensure continuity of treatment and ensuring viral load testing. So, we can talk about that at a later date, but today just wanted to really focus on case finding of children. So the take-home points, number one, we talked about the new KYCS Plus register and the importance of binding women to their children in smart care, and that all facilities should aim to complete this by the end of September 2022. And this is going to be a big lift. And so it's going to require, potentially additional manpower, additional data associates to be able to either filling out the paper register or doing the binding in smart care and calling up women to find out about their, the children who reside with her. And then we also talked about how KYCS Plus will include non-biological children under 19 living in the same household. And then we also touched upon the importance of making sure that all facilities, especially the small to medium-sized health facilities, complete KYCS. Because so far we've only been focusing on the high volume facilities. And then we also don't want to forget about retesting of the negative pregnant breastfeeding women, especially the breastfeeding women, because this is where many of the incident infections are happening. And then also that exposed infants need a final outcome at 24 months. So that is the end of my talk for today, and I'll pause here for any questions. Thank you.
Thank you so much, Dr. Meg. We appreciate such a great presentation, and I do hope that the people on the call have been able to learn one or two things. So before we proceed to the question, perhaps we could just run through the poll questions one more time so that those questions that were not so may not have really been sure about, we can do that. So dear network, try out these one more time, and you can just poll which one you think is the correct answer following the presentation. and then Dr. Meg will be able to run us through at its stage. So which testing modality contributes to the largest proportion of pediatric testing volume? Is it A, index testing? Is it B, other PITC? C, both 1 and 2 are correct. So I'll just give you a very short time to poll, because okay, great. I'll end the poll, and then I'll ask Dr. Meg just to run us through this particular poll. Dr. Meg?
Sure. Okay, so this was a bit of a trick question, right? Because all of these are technically correct depending on when you're talking about. So basically, the answer is, if you're talking about today, the highest contribution of just purely testing volume is coming from OPD and from the other PITC modality, because we suspended this risk screening tool, and as a result, the number of tests being done through this modality has really doubled in the last quarter. But unfortunately, the actual number of children identified through this modality has decreased. And so, I think we're playing this balance of needing to test, as many eligible children as possible without missing any children who need to be tested. But at the same time, we need to weigh that against, the limited number of test kits that we have, and the resources, the time on the healthcare workers and the testers. So, for now, I don't think we're making any changes, but please know that there may be a new risk screening tool coming down the pike in the next few months, so that we can be more efficient at identifying positives through OPD.
Thank you so much for that. So I'll end the poll and launch the second poll. I hope we can see it. So this particular question is asking, which testing modality contributes to the largest proportion of positive children? Another very interesting question. So dear network, you can pick which one you think is contributing to the largest proportion to the positive children. So just give you another 45 seconds. Okay, so I'll end the poll. Dr. Meg, kindly run us through this one.
Sure, yep. So 80% of you got the question right. So yes, the testing modality where we're finding the most number of children is still index testing. This continues to be the most important testing modality for us. That being said, we need to make sure that we're doing KYCS not just in the largest facilities where we're having the surge activities, but we also need to make sure that this is happening in the smallest of the facilities, right? And this may be difficult because some of these facilities don't have the human resources to be conducting these tests. And so partners need to be very creative about how they reach these the clients at these facilities. And that could take a form of like a roving testing team, or some sort of flexibility in testing the children whose mothers access care at the smaller facilities.
Thank you so much. Final poll question. According to the latest spectrum estimates, what is the most common source of new pediatric infections? From mothers who did sorry. So from mothers who were infected during pregnancy, from mothers who dropped off ART during pregnancy, from mothers who were infected during breastfeeding, from mothers who started ART late in the pregnancy. I think we did have a slide on this, and I hope we remember. So I'll end the poll. Dr. Meg, kindly take us through.
Sure. And again, 80% of you got it correct. So excellent. So yes, the highest contribution of new positives are coming from those mothers who are infected during the breastfeeding period, according to the spectrum model. So really underscoring the importance of retesting during breastfeeding so that we can, pick up these women who are infected, after they give birth, so that they can be started on ART and their babies can be started on prophylaxis.
Thank you so much, for this presentation. At this particular time, I'm going to invite the network to raise their hands, and then we can call upon them, and then we can give some responses. We have been joined in the hub by one of our experts who on the call, and so whatever there is a question, we'll invite Dr. Rutagwera to also be able to respond to some of these questions. Dr. Muviana, please do unmute and ask your question. I saw your comment in the chat. I'm glad you raised your hand so that you could amplify your question in the chat. Please go ahead. IT assist with unmuting.
Thank you. Thanks very much, Meg, for their presentation. My question is if there's any consideration to have measuring coverage by the number of children needing to be tested, apart from just measuring it based on the number of women who have children that need to be tested. I think it would be good if we did that, since I think different women have different numbers of children. One could have 10, another one has 2.
Yeah.
So if 2 are not complete, it's incomplete coverage. If we have tested 9 out of 10, it's incomplete, but I think you've done better. Yeah, so if there's any consideration moving that direction.
Yeah, no, absolutely. Thank you so much, Dr. Muviana, for that question. As you rightfully pointed out, there are really 2 ways of reporting KYCS. The one is using the number of women as the denominator, but then you could also use the number of children who need to be tested as a denominator. And I think the beauty of this new register is that you can actually do it both ways. If you just tally up all the children listed in this column, then you can certainly get that denominator. And then the numerator would be the number of children with their status known, which will be here, final test result. So certainly I think this can be done both ways. And the way I believe SmartCare kind of spits out the report is more of a line list of all the children. So in a way, that's going to be an easier way to report it out, rather than aggregating at the women level. But I think the beauty of this register is that you can do it either way. And perhaps what we'll do is report it out both ways, because as you mentioned, I think the coverage rate will be much higher if you use the children as a denominator versus the women. So yeah, certainly open to both ways of doing that. Over.
Yeah, thanks. I think that's a brilliant question, and I agree with your response, Dr. Meg. Do we have anyone on the call who would like to make a comment, a clarification, perhaps even any of our experts who would like to just give a voice to this subject matter here. We have Kennedy, kindly unmute, and you may go ahead and make your comment.
Thanks very much, and thanks for the presentation made. The data presented seems to indicate that even if we have increased testing through the suspension of the HIV risk screening tool for pediatrics, the number of positives identified through that modality has actually decreased, indicative that the children that we need to find may not be those that are visiting the facilities, but out there in the community. And so clearly index testing is one strategy that can help us reach those children. But as presented by Meg, we need to find these other healthy children who may not necessarily be sick out there in the communities for us to be able to meet our pediatric targets of children that we need to find. I submit.
Very, very valuable addition, Nkwemu. Thank you very much for that. Any other comments, clarifications, additions? So Dr. Meg, I was talking to one of my colleagues and he was asking me, you pediatric people, where are the children? Where are we going to find them? And I tried to answer, but they were not too satisfied with it. But I think your presentation seems to be highlighting and emphasizing that there could be children out there who are actually linked to some of our women that are on treatment, and also your emphasis to see some of the final outcomes at 24 months, where we were not doing so well there. That also gives an opportunity to see where we can find these children. Any comments on that, just for emphasis sake?
Yeah, no, I mean, it's a fair, question that we often get, right? We're spending so much, expending so much effort and resources into finding children, and yet we're not finding that many. So, I think sometimes people call into question the CLH-HIV estimates, which is fair, but at the same time, we have to work with some sort of a number that we're striving towards. And the new CLH-HIV estimates of about 60,000, it's about 10,000 less than what we were working towards last year. So, and that's the best estimate that we have, right? So we have to really assume that's correct, and until we essentially, get to 100% KYCS coverage, we really can't prove that, we've tested every exposed child, right? Every child born to a positive mom, or every child who is at risk for getting infected. And so that's why it's important to be able to implement this register so that everyone is reporting the coverage correctly. And so once, we're at a point where every facility is saying, hey, we've reached, 95%, near 100% coverage of KYCS, and yet we really haven't found the children, then I think we have evidence to say, maybe the estimates aren't truly correct. But until we get to that point, we can't really say that. So, and then once again, if we can't capture children through KYCS for whatever reason, if they're orphaned and don't have an index parent, I think these are the children that we need to find through our community partners.
Thank you so much. Any comments from the other panel of experts? So Dr. Rutagwera.
Thank you so much, Dr. Ziambo. I think for me, what I can urge the facilities listening in today is that I think we need to do an audit, make sure that we document all our women that we have in our care, and then just to make sure that we are also updating the locators correctly so that we're able to know which women have had all their children tested, as well as the other household members. And at the same time, for all of us that have smart care in our facilities, let's also update both in smart care as well as on file. For IFES sites, let's ensure that we do not forget, as we bind these children to their mothers, let's not forget to update the testing module as well, because the index testing register will really look at the number of children that have had their tests. So if we just update the locator and not update the testing module, we may not know the HIV status for these children. Thank you.
Very timely reminder. Thank you very much. I've seen a hand. Yes, go ahead, Dr. Rutagwera.
David on the line. So I wanted to emphasize a few things. One basically is a clarification from Dr. Meg about retesting of the children that are above 10 years old. And she said every child who is above 10 and they don't have a test within the past 6 months should be retested. I think one interpretation that can come from this is interpreting this as meaning that basically if children are above 10 years, they should be retested every 6 months. And I wanted her to clarify that. And then in terms of emphasis, so it's true that we are looking for children mainly in health facilities and in processes that are initiated from the health facilities. But we've been doing this for several years, and probably we have almost exhausted these avenues. So community testing by OVC partners and identifying actually these vulnerable children out there that probably have nobody to bring them to the facility, or they are not linked to anyone who comes to the facility regularly, is an interesting avenue at this point in the epidemic. And this is something I think we need to focus on. And together with this comes the social network strategy for older children and adolescents, which is quite very promising. And we seem to find a number of these children through this process. And this is something I would like to encourage facilities to look at, in addition to family index testing. Thank you very much.
Thank you very much for that important comment. Dr. Meg, you want to maybe address the age issue?
Yeah, the age issue. So, David, this is something, the TWG spent a bit of time discussing, and definitely would appreciate your input as well. Because, we were debating whether or not 10 years is too young to be using as a testing cutoff. And, but really wanted to balance out, the fact that children are potentially having sex earlier in life. And so we wanted to be able to capture those children who may be getting infected horizontally. The national, testing guidelines don't really spell out how often and when children should be retested if they've been, previously tested negative. And so this is sort of the agreement that we came to. And so, if you feel like, and if other, subject matter experts on testing feel like 10 years is too young, or every 6 months is too frequent, or even, you know, not frequent enough, then I think that's something that we could consider. And, you know, I think it's not a retest, like we're not going back and retesting these children over and over again. It's really just a point in time when we assess the status of these children associated with a woman. Then at that point, we would do testing if the child has not been tested in the last 6 months and it's over 10 years of age. So hopefully it's not going to require retesting of these children every 6 months. But like I said, you know, if we end up having too many children who need to be tested as a result of this criteria, then we may need to increase the testing cutoff to like 15 years of age or something like that. But would definitely, you know, appreciate your thoughts on this. Thank you.
Thank you so much, Dr. Meg, for that response. And I do agree, when we met in the TWG, there was just that sense to be a bit inclusive in considering the age of sexual debut. In a few of the studies that have been done, the surveys that have been done, they're showing that the sexual debut is as low as 10 years in Zambia. And so that's how come it was widened to that low. And as we closely look at this implementation of the register and all things considered, I think it will still be going reviews and further clarification and streamlining. Thank you so much. Dr. Itoh, you would like to make a comment? I've seen you've raised your hands for quite a bit.
Thank you, Dr. Ziambo. Thank you. Are you able to hear me?
Loud and clear.
Thank you, Dr. Ziambo, and thank you, Meg, for the presentation. So probably I may have missed it. I just wanted Meg to clarify, because I know in the initial KYCS, we're looking at women that were in the childbearing age, so up to 49, I remember. So now that we are going to KYCS Plus, looking at children, even non-biological children to be tested, I was just wondering whether this time around, in terms of a baseline, we have to look at all women that are in care rather than only those that are in the childbearing age. I didn't get that, probably because I have an erratic connection of internet. So I don't know, Meg, did you clarify on that one?
Yeah, thank you so much for that question, Dr. Leja. Yes, excellent point. So that is a difference between the old KYCS and this new KYCS Plus. So, you know, I think setting a cutoff for 49 seemed like we could potentially miss out on women who either, you know, became mothers at a later age, right? It could be like in your early 50s and still have like an 18-year-old, I suppose. And as well as, you know, if we're expanding the children to the non-biological children, just, you know, as long as they're living in the same household, they should be tested. We felt like, you know, in the spirit of inclusivity and making sure that we're not leaving any children behind, we thought we would, you know, essentially provide opportunity for every woman, regardless of age, to have the opportunity to be included in KYCS. And of course, if the answer is no, I don't have any children under 19 years of age, or, you know, living with me, or either biologically, then at that point you just, you know, stop and, you know, move on. So yes, so the answer to your question is yes, you're going to be including every woman regardless of age. Over.
Thank you for that response. I don't see any comments. I don't see any hands. The network, are we okay so far? We don't have a case for you today, so we just wanted to make sure that we have a very exhaustive discussion on this subject matter. I know there was a question asking when we will have these registers available. We just running through the usual protocols of the registers being approved through the MOH hierarchy, and then we should be able to make them available in good time. Thank you. Dr. Ledger, again, it's you.
Thank you, Dr. Ziambo. Sorry, it's just a follow-up for Meg. That's very clear and loud, the way you explained it. So I was just wondering if the TWG also consider the children that are being kept, let's say orphans that are being kept by negative mothers. Did you think of how to capture them as well? Because, I mean, being in an African society, there are children that are being kept by a parent, but I mean, by relatives that are negative, and yet probably they were born from positive mothers, probably late positive mothers who have died. So I don't know if you thought of how to capture those children as well. Thank you.
Yeah, excellent question. Yes, we did have a very extensive discussion about that issue. But, you know, we felt like KYCS, the window into KYCS is the positive women, right? And so we didn't want to change that aspect. But recognizing that there may be quite a few, you know, orphans out there who may not be captured through their index parent, we think this is where the community partner comes in, right? We know that our OVC footprint is expanding, and we're also going to have, you know, more community partner presence for testing. And so these are partners who have, you know, who have their fingers on the pulse of who's most vulnerable in their communities. And so it's through these partners that we hope to have, we hope to reach these children who are most vulnerable and may not be, you know, reached through index testing. But in order to sort of make sure that we're very clear about what KYCS is, we did not change the fact that the entry point into KYCS is a positive woman and not, you know, other households. Over.
Thanks, Dr. Megan. I think the emphasis is to remember that we are trying to actually exhaust who the children we feel we can find, and that are through family index testing. And then we're hoping, like Mr. Nkwemu emphasized, the need to go into the community as well, and which is what we should be able to address children of negative parents. Thanks for that important questions, Dr. Lega. I've seen Annette from Avincian raise your hand. Please go ahead and mute and make your comment. Annette, please.
Good afternoon. Thank you very much. Sorry for the silence. I was trying to navigate the unmute, but the host has allowed me to unmute. So my question is on the, of course, the biggest question is where are the children? And I just wanted to find out with regards to children who are children and adolescents, of course, who are in orphanages, who are being kept in orphanages. I know our community partner who's going to handling or who's handling OVC. Do they have any strategies for testing children who are in these setups? Of course, we're discussing children who are in maybe household setups, but what about these children who are in the orphanages? Do we have any specific strategies for these children? Thank you.
Thank you for that question, Annette. That's an excellent one that I'm not able to answer just because I don't know. I'm wondering if there's anyone on the network who's representing the OVC partner or anyone who can answer that question.
Yeah, thanks. Any of our colleagues from the network, the kind of experts, I think there's an interest here. We would like to find out what sort of strategies are being used to reach the children in the communities that are orphaned. Mr. Nkwemu, any thoughts on that? Okay, subsequent to, yes.
Yeah, so for the children that in the orphanages, I guess we need to find a way of working closely with the people that are running the orphanages. And I know, for example, the Ministry of Community Development and Social Services comes into play. And so there might be, there obviously will be a need to engage them, to explain them to explain to them the purpose of why there is need for these children in orphanages to be tested, and the benefits around knowing their status. That would be one of the things that would need to work around to bring everybody on board. It's not as straightforward as as we're speaking, but this is something that we definitely need to address. I submit.
Thank you so much. I've seen 3 hands, so perhaps we can have Aline, Piri, then Robert, and then John Kamona in that order. Kindly, I hope you're responding to the question that was raised. Thank you. Aline?
Hello, can you hear me?
Loud and clear, thank you.
Okay, thank you. It's telling me the host is not allowing participants. Okay, yeah, so just to add to what Kennedy has said, I think we need a holistic response in the community. And I think one of the things that Meg said, I think it was Meg who said, we want to work with our community partners because they have the pulse of what goes on in these communities. So I think working with the community partners to identify where else these children are. Yes, the strategy is to work with families, but I think working with these community partners, they will also be able to point out to say in that we have an orphanage there, and there are children who could be HIV positive. So maybe we need to look at that. So it's really having a holistic approach to finding these children and working with all partners, since our community partners will know these communities where we work in, and of course, bringing in the Ministry of Community Development. So I think we should not be limited by, oh, we are doing family indexing to find the positives, but what else, who else is out there in these communities that we can reach out to and find out their HIV status, as we are trying to find all the children that are HIV positive. I just wanted to add to what Kennedy was saying. Thank you.
Valuable inputs, Madam Aline, and I think that's something that probably the HIV testing services team at MOH and other partners need to coordinate and try and explore to see how we can coordinate that. Robert, from CRS, I've seen your hand. Maybe you could also make your comment.
Good afternoon, everybody.
Good afternoon. Go ahead.
Yeah, thank you so much, Dr. Maggie, for the presentation. I think the main issue that we keep on discussing is finding these children. So I just wanted maybe to propose one opportunity that we can equally take advantage of. I think if you look at HIV case identification, especially among students, I think it's time we started looking at this issue multi-sectorial. And of course, take advantage of activities that are coming up. So I was thinking that since Zambia is about to conduct their census exercise, I was wondering, as the technical working group, how best can we partner with the Central Statistic Office to make sure that we capitalize on this opportunity and provide HIV testing to those children that are not yet testing. It can either be conducting the HIV testing, or rather also using this exercise just to map out and know where these children are found. Then we can engage other community partners to provide the service. So I was just thinking, the way we do it during the Child Health Week, how best can we also utilize this opportunity to make sure that we reach those children that are not yet found? Thank you.
Thank you so much. We can hear from John Kamona.
Okay. Thank you so much, and good afternoon, everyone. Thank you so much, Dr. Meg, for the wonderful presentation. I represent one of the organizations that are running the OVC programs in the community under the DoD project. Basically, for our project, we're targeting more of the military population and the surrounding communities where we're targeting these children. And so far, I think the project is working on well. But the issue that has come up now, where we're talking of children in the orphanages, I think it is something really that we need to think around. And maybe my thinking, and at some point I was discussing with one of the guys from USAID, that maybe we need to have like an interagency or the partners where we come together, including community development and Ministry of Health, like a technical working group specifically for these children, the orphans and vulnerable children out there, so that we map out and strategize exactly how best we can penetrate in these orphanages. Because we are aware that most of the children that are in these orphanages could be infected with HIV, maybe their parents died of HIV and AIDS, we do not know. Meaning that even if we're talking of epidemic control among the children, it will be difficult to attain that, because those children that are confined in these orphanages are not provided with the services. So maybe Dr. Ziambo, it is something that we really need to start thinking around and see how best we can address this issue going forward. That is my contribution, and in addition to what others have said. Thank you.
Thank you so much. Contribution noted. Any remarks, any responses, Dr. Meg, to any of those raised contributions, clarifications?
Yeah, I mean, it seems like testing in orphanages seems like a very low-hanging fruit that we should certainly pursue. Yeah, for sure. And I agree that, you know, having a TWG conversation with engagement of MCDSS would be a wise thing to do. Regarding the gentleman's comment about the census, I mean, that's very intriguing. I don't know what the scope of possibility is during a census. I imagine that, you know, HIV testing would be hard to include, but I may be mistaken. And if it's possible to, you know, it's almost like a FIA, except that it's essentially knocking on everyone's door, right? And so, yeah, I'm not familiar enough with the process to comment, but it seems like a very opportune time to take advantage of, you know, the reach that the activity would have. So yeah, certainly I think willing to think about that possibility. Thank you. And eager to learn more about it. Thanks.
Yeah, very, very interesting thoughts that have come through. Thank you very much, everyone, for this wonderful discussion we have had today. And I think we do hope that this will now materialize in some actions being taken from here, and that is ensuring that we have this register out there, and we have some of these strategies discussed, shared, and then also implemented. We should be wrapping up now. We've been on the call for close to an hour and 30 minutes. I want to thank Dr. Meg for putting this up together. I think it's been a great presentation. Thank the the panel experts that have been on the call. Thank you very much for your inputs, and our participatory, very active network. Thank you for joining us. Are there any last words, Dr. Meg, you want to give?
No, just a big thank you for everyone who participated today. And, you know, we don't have the answers, right? We keep asking, where are the children? We are, you know, doing our best to find them. But if you have any great ideas from your work on the ground, please, you know, reach out to me directly or the TWG, and let us know of any good strategies that you may have. And once again, thank you so much.
Thank you so much, everyone. We have come to the end of the session. We'll see you next week. Do have a lovely day. Bye-bye.
Bye-bye. Thank you.
Thank you.